Hello, everyone. It's a great pleasure for me to be here to giving this webinar. I would like to thank to Dental Tribune Study Club for the opportunity to give this webinar. And the topic I bring here today is about biomaterials in endodontics. And I try to make a search in literature and try to find some key points about these kind of materials that have an impact in our clinical practice, in our daily practice, and how we can improve our endodontic treatment with these kind of materials. Before beginning, I would like to introduce myself. My name is Hugo. I live in Portugal, and my clinical practice is limited to endodontics. And I have the honor to be invited in 2016 by Professor Marco Veziani to be part of one amazing project, the book Root Canal Anatomy in Permanent Dentition, and I'm co-author in one of the chapters of this book. I invite you to see this book. It's an amazing book about root canal anatomy related to endodontic treatment. These two cities are in the north of Portugal. I live in Vila de Conde, and I work mainly in Oporto region. And I invite you to come and visit me there. I'm going to begin my lecture explaining a little bit about the endodontic treatment. The main goal of endodontic treatment is to provide an adequate control of bacteria inside the root canal system. And we need to do shaping, disinfection, and obturation procedures to achieve this goal. We have a sequence of steps from diagnosis to restoration. And if you follow all steps in a meticulous way, we can achieve a very high success rate. Imagine this clinical case. In 2012, I received this patient with a huge apical lesion, and I do the root canal treatment, and after 5 years follow-up, I have amazing healing in the apical area without any lesion, tooth in function, with a very, very nice, very good outcome. And all of you know that the success rate is very high. We have around 94% of success rate in situations without apical periodontitis. But even the success rate is very high, we have one important factor, the X factor. And what is the X factor? The X factor is the clinician knowledge about endodontic treatment, about all procedures, the skills of this clinician. And it's important to understand that the outcome is they have a multifactorial nature. We have preoperative factors, we have intraoperative factors, and we have postoperative factors, and both of them have a relation between each other and have an impact in our endodontic outcome. But from these prognostic factors, probably the root canal infection, the bacteria, is the most important or the key factor related to the success of our treatment, related to the treatment outcome. And this relation is not new. You know, the Science Kakehachi in this classic article show us that we have a direct relation between the presence of bacteria inside the root canal and the presence of apical pathology. And we have other authors like Professor Domenico Ricucci, Siqueira, showing that the treatments failed because of the presence of bacteria inside the root canal system. But with this article from Professor Siqueira, he explaining us that with our procedure, we only need to do a treatment that can reduce the amount of bacteria inside the root canal system below from this level. If you can achieve this goal, if you can reduce the amount of bacteria you have inside your root canal below to this line, this subclinical line, we can achieve a success rate with our treatment. We can have healing. Before beginning the topic, I would like to raise 3 main points. I would like to raise the importance about the knowledge of internal anatomy. It's important to the clinician understand that the internal anatomy is very, very complex, and the knowledge about canal morphology and variations is very important for this kind of success. And a very good example I'd like to give is related to marketing, is related to this logo. When you look to this logo, it's possible to see that we have letters and we have 2 colors. But they have more information here. When you look, you see this arrow. Now, when I remove the line in the arrow and you look again, you are always going to see this arrow present in this logo. We only identify the things we know, and in anatomy it's happening exactly the same. We need to know about the variations in different kind of anatomies, and in this way you are going to be more able to identify these variations in our clinical daily practice. Another important topic to raise is the action of our files. They're going to left 30 to 6% of areas of our root canal system without any kind of action. And in this way, it's important to understand that the files only go to create space for the action of our irrigants. We are going to shape for create more space to deliver our irrigant inside our root canal system. And the last point I would like to raise is related about the type of bacteria we have inside the root canal system. We didn't have planktonic bacteria. We are going to have inside the root canal system biofilms, very well organized, and it's very difficult to remove and clean this environment because they are working like a team. They are protect themselves from the action of our antibacterial agents. But it's not the only factor. Even accomplish all these steps in a great way with a very good protocol, you need to be aware about some procedural mishaps. We need to have very careful about our treatment to avoid any kind of mishap, because these kind of mishaps can have a direct impact in our outcome. And as endodontist, I receive a lot of patients in my clinic with a lot of problems, with a lot of challenging situations like these separated instruments, ledges, some clinical challenging situations like internal resorptions, situations with apical inflammatory resorptions, with strip perforations, situations of trauma in immature dentition, and focal and radicular perforations. And it's very challenging for us. We need to improve ourselves. We need to improve our practice. We need to improve our knowledge. We need to study. We need to have adequate armamentaria, adequate devices in our office, CT scan, magnification with microscope or loops. And we need to train a lot to have practice. And finally, we need to have the adequate armamentaria. We need to have adequate devices. We need to have adequate materials. We need to have materials that can improve the outcome of our treatment, can help the clinician to improve the outcome of the treatment. And when you look to the history of materials, we can see that the last 4 years, the materials we have available did not possess the ideal characteristics for repair a lot of these kind of situations I show you. And MTA appears in the market, and probably they give a new change, new option, new opportunity to maintain some situations, some challenging situations. And it's why I begin my lecture with this question. The bioceramic materials, they are really the new hope. And for beginning, I show this case. It's a lower molar in a patient with a huge apical lesion with pain, with a previous root canal treatment. They have an inflammatory resorption, they have strip perforations. The patient didn't have money to do an implant, and they asked me if it's possible to keep the tooth in the mouth after retreatment. I explained that the prognosis is very, very bad. When I do the retreatment, the mesial root, they have removing the gutta, they have a lot of bleeding, they have a perforation in the root, and the outcome is very, very bad. And I explained to the patient, but we decide to do the treatment. I decide to do an obturation with the MTA in the distal and the mesial root canals. To deliver the MTA, I use a MAP1 device, a device that helped me to deliver the MTA to the inside the root canal system, inside the root canal. And it's very difficult. I need to use a lot of MTA in the mesial root to stop bleeding and to allow me to obturate all the root canal with the MTA. And I explained to the patient in the end of the appointment that probably the tooth is going to need to be taken out 2 or 3 days later, because the situation is very, very, very bad. And the patient returned to my office only after, with a provisional restoration, only after 3 months. And I have here the final X-ray and 1 year follow-up. This 1 year follow-up is possible to see that I have a completely healing in the apical area. The result is completely amazing. I can recover all bone in the furcal area and in distal area, and I have a tooth with a very, very prognosis, very bad prognosis in the beginning, can keep in the mouth 1 year later. And now I have 2.5 years later, a follow-up X-ray. The patient have the tooth in function with onlay, with a situation that allow me to keep the tooth in the mouth with the right treatment and with the right materials. And they give me a new hope in that kind of situations. And to prepare my lecture, I decided to make a search in PubMed about MTA, about what literature we have nowadays, and we found a lot of articles. We found around 2016 references about MTA, about mineral trioxide aggregates. And I'm going to begin giving you one small idea about the history of MTA. And the Portland cement was invented in 1824. And the first reported use of Portland cement is from 1878 by Dr. White, a German dentist, in a German publication. And the father from modern MTA is Dr. Mohamed Torabinejad from Loma Linda University. They registered 2 patents using the Portland cement. And in these 2 patents, we can find that the favorable physical properties are attributed to their effective seal against the reentrance of infection organisms inside root canal. And nowadays, we have more than 20 patents in the United States and Europe using the Portland cement for dentistry. We have a lot of materials nowadays, and thanks to Dr. Mohamed Torabinejad, they was the responsible for the development of first generation of calcium silicate cements. They developed in 1990 at the University of Loma Linda as root and filling material, and first time described in literature in 1993, and was approved by FDA to use in endodontics in 1998. The first commercial available product was from Dentsply, is ProRoot MTA, the gray MTA. The main composition of these MTA is Portland cement, around 75%, mainly tricalcium silicate, decalcium silicate, tricalcium aluminate. They have 21%, around 21% of bismuth oxide, the radiopaque agent, and around 4% of calcium sulfate dihydrate or gypsum. They are related to the setting time, to alter the setting time. And they have minor trace elements can be present in their composition. Their main clinical application in the beginning is as root and filling material, but taking into consideration these hydraulic properties and their sealing ability, they show a huge potential to be used in other applications like pulp capping material, root resorption situations, in repair of perforations, furcal perforations, root perforations, like obturation material, in apexification situations, and in microsurgery. How to mix the MTA? We see in the literature that the water to powder ratio influences the amount of solubility. In higher water to power ratios, they're going to increase the MTA solubility and the porosity. It's important to follow the protocol of mixing, and it's important to see in different types of MTA different indications of mixing. In this one, for example, from Product Inter, the MTA white, they explain that the mixing need to be 1 drop of liquid with 1 sacket of MTA, and the mix during 30 seconds to achieve like this wet sand consistency. Let's see this video showing how to mix the MTA. I'm going to use 1 box, 1 sacket of MTA, and I'm going to use distilled water. I'm going to put 1 drop of the water, and I'm going to mix both parts, the liquid and the powder, until achieve this wet sand result, around 30 seconds. When I achieve this result, this wet sand consistency, I can use my delivery device, like my MAP1 device, and I'm going to fill the MAP1 device with the MTA. Clean the tip, and in this way I can deliver the MTA, the cylinder of MTA, very easily and very effective inside the root canal, inside the perforation, to the apical part of the root canal in a microapical surgery. The MTA have a lot of advantage. They have low cytotoxicity, excellent biocompatibility, they are hydrophilic nature, radiopaque, sealing ability is very effective, and it is bioactive. But they have this fourth generation have some disadvantage. They are more difficult to manipulate. They have a long setting time, the cost of the material. And let's see the properties of MTA. The hydrophilic nature. MTA is hydraulic type of cement. That means that they set by reacting with water. When you look to the reaction, when we mix the calcium silicate powder with water, I'm going to have mainly two products, the calcium silicate hydrates and calcium hydroxide. All the beneficial properties of the MTA are related to its hydraulic nature. And the amount of calcium hydroxide produced in MTA has been found around 10 to 15% of the hydrated material. We need to have this wet environment. We need to have water and moisture to happen the setting of the MTA. In situations that we have low amount of water, deficient amount of water, or a huge amount, excessive amount of water, they can affect the setting and properties in detrimental way of my MTA. For example, if I have excess moisture, then can cause increased porosity and wash out the MTA during setting, or even can cause material degradation with decrease in the strength. Another property is related to calcium release by MTA. They're going to exchange osteoblastic viability, proliferation, and differentiation. And this continuous release of calcium from the setting MTA diffuses through dentinal tubules with increasing calcium ion concentration during the prolonged curing process. When we have these calcium hydroxides, they are released in solution and in contact with phosphate containing in tissue fluids, then can form hydroxyapatite. And it's related to another property. During the setting process, form hydroxyapatite and establish the chemical bonding with dentin. They observed that this bonding going to create like interfacial layer between the MTA and surrounding dentin. The apatite formation contributes to leakage reduction not only by filling the gap along the interface, but also via interactions with dentin during interfibrillar apatite deposition. Another important property, the alkalinity of the environment, is unfavorable medium for bacterial growth. When you look for different kinds of MTA where only have this alkaline environment with a high pH value, this sustained alkaline pH is a potent antibacterial and antifungal property. MTA is shown to be effective in bacterial elimination and to decrease bacterial viability. Their bioactivity. MTA can provide important advantage due to its bioactive and bioinductive properties. Their bioactive nature is brought about the dissolution of calcium, which then complexes with phosphate to form hydroxyapatite crystals that grow and fill space between MTA and dentin. Over time, this mechanical layer transforms to a chemical bonded seal. This hydroxyapatite and this calcium going to induce pulp and perinatal cell differentiation and mineralization. Mta induces pulp healing and regeneration. The chronic inflammation is minimal when we compare Mta with other repair materials. The hydroxyapatite is essential for mineralization, and the histological findings show that cemento formation underneath all Mta samples. We have a biological repair that implies that cement or bone will be covered by surface of set Mta. When you look to this histologic image, I'm going to have here the Mta, and underneath the Mta, I'm going to have a regenerated parental ligament and regenerated bone. This hydraulic calcium silicate-based cement has been shown to exhibit excellent biocompatibility and pronounced osteoconductivity. Several histological studies have found that thick cement was deposited on the surface of Mta root and fillings, confirming that Mta biocompatibility and bioactivity. When you look to this histologic image, I'm going to have here the Mta and a new formed cement and a new formed bone under the Mta. We have several studies that show that Mta has the capacity to promote hard tissue formation. And about the sealing ability. The sealing ability of Mta was superior to other materials, and the marginal adaptation from the Mta was better than amalgam ERM or super EBA. One reason for the sealing ability of Mta is its slight expansion upon setting. The formation of hydroxyapatite crystals between the Mta and tooth interface has been implicated in the excellent sealing property reported for Mta. And about fracture resistance, the teeth root filled with Mta have been reported to exhibit greater resistance to fracture than untreated controls. Mta may provide exchange resistance to fracture and also contribute to strengthening of tooth structure. But sometimes the environment can have an action in my Mta, and in literature we found some information about that, about the acidic environment in situation of inflamed pulp or periapical tissues. I'm going to have a reduction of calcium hydroxide formation. And about the contamination with blood in furcal perforations and apical surgery, they can compromise compressive strength and micro hardness. Even the exposure of Mta to calcium agents like ADTA, they can disrupt the hydratation of Mta with no formation of calcium hydroxide. And in this situation, what I can do a flush with distilled water after my irrigation with ATA, for example, to remove any trace of chemical elements inside the root canal. And after that, apply my Mta. And about the interaction between or the importance from smear layer for the fixation of Mta inside the root canal. The smear layer can act like a coupling agent. Same situation that happens with restorative dentistry that exchange the Mta bonding to the root canal dentin. But the data we have in literature about this information are inconclusive regarding smear layer removal. Clinicians may choose to leave the smear layer in selected cases and fill canals with Mta without apparently compromising the outcome. And about the mixing agent, you can see some colleagues using anesthetic solutions, sodium hypochlorite gel, chlorhexidine, for example, to mixing the Mta. But you can see in the literature that these kinds of mixing agents can have an influence of compressive strength of the Mta. When we mix with saline, we are going to have a better compressive strength, or even using hypochlorite, sodium chloride gel. And these graphics show the influence between three main variables: the mixing agent, anesthetic solution or sterile water, and the pH of the environment, acidic environment or a neutral environment, and the developing the time between the application, 7 days after application, 20 days after application of MTA. And it's possible to see that the acidic environment and the anesthetic solution is in this kind of situation when you mix the MTA with anesthetic solution and you put this mix in an acidic environment, I'm going to have a lower compressive strength of my MTA. And this first generation of MTA, the MTA from ProRoot MTA, first version gray MTA from 1998, they show some drawbacks. They have long setting time, they have handling difficulties, the discoloration of remaining tooth structure, and the costs. And they decide to introduce in the market a new version of the MTA in 2002. One white version of MTA. In this white version of MTA, they removed the iron from the first version to avoid this tooth discoloration. But we can see that the problem remains the same because the bismuth oxide has also been implicated in tooth discoloration. Tooth discoloration has been reported with use of both gray and white MTA. And it's why a lot of companies try to introduce a new calcium silicate cement in the market to avoid to pass some of these drawbacks, like long setting time, the tooth discoloration, the difficult handling and manipulation of MTA, and the risk of washouts. And in this table, you can see a lot of MTA versions available nowadays in the market. And I'm going to pick in this example from PD MTA White. And it's possible to see with this new version of MTA from Product Mta that they introduce a new formula of MTA, a bismuth oxide free formula. They have mainly the same composition, tricalcium silicate, decalcium silicate, tricalcium aluminate, and calcium oxide, but the opacifier agent is not bismuth oxide anymore, it's calcium tungstate. And with this introduction, with these changes, they're going to have a better setting time, around 15 minutes setting that allow to do the final restoration same appointments. The new version of MTA with a new opacifier agent avoid staining and discoloration of tooth structure. And because we are talking about white MTA, they have a fine powder particle size that more easy to manipulation and work with this kind of MTA. Okay, let's see what you have in the literature and try to translate this information for different applications and try to see them in a clinical point of view. About root and filling materials. In the literature, you can see that the sealing ability of MTA and the other hydroxyl calcium cements is extremely well documented in vitro and in vivo on animals. Basically, this kind of material applied in root and cavities demonstrate an efficient and durable seal. They are very biocompatible. When we compare with old materials like amalgam, resin, glass, normal cements, IRM, they have better results and they accomplish more properties related to the ideal root and filling material. Based on current available studies, MTA appears to be the material of choice for root and fillings. Let's see this clinical case. It's a clinical case in a patient, a female patient, with a Piccolo lesion, with extrusion of obturation material. The patient have complaints, they have pain, and we decide to do an apical, microapical surgery to remove this material outside the root canal and do the preparation retro obturation with the MTA. I decide to do a papilla-based incision. The release of my incision. For the osteotomy, I use a piezoelectric device. The curettage of the lesion and the extruded material from the apical part. The apicotomy. retro observation, retro inspection, retro preparation with ultrasonic tip, and as I told you, the contamination with blood can affect the strengthening of the MTA. And to create an environment without blood, I use this technique described by Dr. Kim in his book to use gauze, pieces of gauze with anesthetic solution inside the preparation area, and make some pressure of these gauzes, this part of gauzes with anesthetic solution. And after 5 minutes, around 5 minutes, I removed the first ones and I left one inside to keep the environment without blood. And now I do the retro obturation. For retro obturation, I use MTA and I use a delivery device. Why it's important to use a delivery device? You can see it's very difficult to placing the material in the retro prepared cavity. And we have in the market some device can help the clinician to deliver the material in a more effective way to the retro apical area. We have this map surgical kit with some tips with different angulations for posterior area, but with different sizes, with different colors, with different sizes. These new devices from Product Inter, they have a huge advantage using this plastic plugger inside the needle that allow to avoid any to have a more effective way. We can do the sterilization of the device. You can do sterilization of these plastic plugs. You can change these plastic plugs because they come more than one piece inside the device. We can avoid one huge problem that I have with other devices, because other devices the plugger is in metal and the risk of breakage is very high. In this way, with this plastic plugger, I'm going to decrease the risk of blockage with MTA, set MTA inside my needle, and I can change this plastic plugger if I need to change it. And I have mainly three sizes, depending on the area I need to work. And for next year, we are going to have in the market this new device, this new needle to application MTA in apical surgery, in anterior dentition, these hooked needles that help the clinician to deliver more easily to the anterior dentition, the MTA. After retroobturation and retrocondensation of MTA, the suture, and I remove the suture 72 hours post-op, and the initial X-ray, the post-op X-ray, and 2 years follow-up X-ray. It's possible to see the healing of the area and the periodontal ligament formation in around all root. And about vital pulp therapy, we know that the best filling for root canal will always be dental pulp tissue. And the maintenance of pulp vitality is also a very important factor. The primary aim of pulp capping and pulpotomy has been to establish an environment that induces hard tissue formation by the remaining pulp cells and seals the exposure site, ultimately contributing to continued pulp vitality. For that, I need to create an artificial barrier between the vital pulp and the external environment to protect the pulp during the healing phase. During a lot of time, calcium hydroxide has been the standard material to use in pulp in this kind of procedures to maintain the pulp vitality. The first published references for direct pulp capping using calcium hydroxide paste were presented by Dr. Herman in 1928. But the calcium hydroxide has some drawbacks, and like the induced dentin bridge is inconsistent and porous, the calcium hydroxide does not adhere to dentinal walls, the sealing ability of calcium hydroxide is quite poor, the material has poor antibacterial properties, and another drawback is related to its high basicity. The calcium hydroxide in contact with pulp locally destroys the layer of pulp tissue and thus creates an uncontrolled necrotic zone. And this necrotic layer induces an inflammation reaction that's going to persist in time. But with introduction with MTA, we can give a new opportunity and a new hope in this kind of procedures. Both gray and white MTA induce visible hard tissue formation with only mild signs of inflammation without substantial necrosis. And the advantage of MTA in direct pulp capping when compared with calcium hydroxide include lower solubility, improved mechanical strength, and superior marginal adaptation to dentin. Current research indicates that MTA is the preferable material for direct pulp capping and the rational alternative to calcium hydroxide in vital pulp therapy. Even with the risk of some tooth discoloration, we can use to minimize this effect dentin bonding agent inside the clinical crown prior to use the MTA to avoid these tooth color changes. Let's see this clinical case just to left some important points to take in consideration. It's important the removal of caries tissue. And when the pulp was exposed, it's important to control the hemorrhagia in the area for successful direct pulp capping. After that, when the pulp tissue stopped bleeding, I'm going to use to put a thick layer of MTA over the exposure site and surrounding dentin. And in this way, I'm going to increase the probability that remaining microorganisms can be entombed inside the dentinal tubules. Let's see this case. It's a upper molar in a young patient with a pulp diagnosis of reversible pulpitis and apical diagnosis of normal apical tissue. And I'm clean all caries tissue, and I'm going to expose a pulp horn. And it's possible to see that I have a coronal pulp inflammation because they bleeding. And I'm going to remove the coronal part of this pulp tissue. And after removal, the hemostasis is achieved. It's possible to see that stop bleeding. And I have conditions to do my pulp capping with MTA. And for that, I use my MAP1 device to deliver the MTA over this exposed pulp. And I use this micro brush to help me to condensate the MTA in this area. For this kind of procedure, I need to have the MTA, a microbrush, and an MTA carrier device that help me to deliver the MTA in this area. Normally, in my practice, I use MAP1, but this one, it's very useful because you can bend the tip, you can adapt the tip as you like it. They have external diameter 1.10 millimeters. Or if you prefer to have a more complex set, you can have MAP Universal Kit with more tips with different sizes. We can do the sterilization of all device and the plastic plugger. And let's see how I set up my device. I have the needle and I have my plastic plugger. And I'm going to put my plastic plugger inside my needle, as you see in this movie. Now I'm going to use my syringe and I'm going to make some pressure and I'm going to attach my plastic plugger in this hole. And it's done. I'm going to attach my needle and it's done for working. Now I can bend, I can give the shape I want to the needle and I can fill my device. After the pulp capping with the MTA, I'm going to use a flowable resin modified glass ionomer cement over my unset MTA just to make a protection of my MTA layer. After that, I'm going to do my final restoration. It's very important and they have a direct influence in the outcome to have final restoration in the same appointment. And I have this another clinical case for my dear friend Hugo. It's an amazing case that it's very easy to see the dentinal bridge after 10 months of the treatment. We can see here the dentinal bridge formation over the MTA. And in apical genesis and apexification procedures, During a lot of time, the main material used is calcium hydroxide treatment, but with a lot of disadvantage because I need to use calcium hydroxide during 1 year, 2 year, during all with a lot of appointments. The patient need to come to a lot of appointments with high risk of tooth fracture and weakening of tooth because I'm using calcium hydroxide during a long period of time. And the introduction with the new bioceramic cements, they became the choice from this kind of situations. With a lot of case reports illustrate the successful use of these kind of materials, Perroot Mta and another Mta products, as apical plugs in teeth with necrotic pulps, open axis, periapical radiosensing, and root resorptions. Mta offers a barrier with excellent sealing properties and a high degree of biocompatibility. One of the most significant aspects of Mta in relation to its use as an apical plug in immature non-vital teeth is its ability to induce a cemental tissue in the periauricular region of the tooth. Mta ability to promote formation of hard tissue presents the potential of biological seal of cementon over the material. And you can have a lot of studies report successful use of Mta in management of non-vital immature teeth. I have here some examples of outcome studies of use of Mta as an apical plug with a very high success rate in situations in studies with a very high recall rates. Let's see this clinical case. It's a young patient in a lateral incisor, upper lateral incisor with a fistula and pain. I do the root canal treatment and I do an apical barrier with Mta. Let's see step by step. I need to do the shaping and cleaning of my root canal system. After that, I'm going to put internal matrix with absorbable collagen. Why it's important? Because in this way, they're going to provide a base on which the sealing material, especially Mta, can be placed and packaged without the risk of extrusion to the periapical tissues. And for application of this barrier and for application of Mta, I like to use the Buchanan continuous wave plugger because I have 3 sizes with different diameters, and in each one I have one tip is in Mta and another one in stainless steel. I can use in a very efficient way and a very safe way the Mta part to make the vertical condensation of my matrix and my Mta. After that, I'm going to do my apical barrier with the Mta, and after that, I'm going to do the backfill with gutta perca. But sometimes when I need to do this apical barrier with the Mta, I have sometimes a problem. Can keep some voids between the different applications of Mta. And to solve this problem, I use ultrasound devices that can help me to make a better adaptation of my Mta plug. It can help me to condensate the Mta in these kind of plugs. Let's see in the same case, because it's very easy to show how it's happened. I do my first application of Mta, I make the X-ray control, I do a second application, and I see that I have a void between the first application and second one. After that, I'm going to use my Buchanan plugger, and with my ultrasonic unit, without any kind of irrigation, I'm going to activate my ultrasonic unit in my Buchanan plug to make a vertical condensation. And in this way, I'm going to make a better condensation of Mta, and I can solve this problem. Third application, same problem, a void between the second application and third application. I do it the same way until to have my apical barrier with around 3 to 4 millimeters length, as you see here. And 2 years follow-up X-ray without pathology, without pain, completely healed situation. You can use another techniques to make the vertical condensation of Mta, like using paper points with different sizes, with different diameters to do the vertical condensation of the Mta, or even you can use in difficult anatomies, in curved root canal anatomies, the plastic plugger from Thermafil can remove the gutta, you can keep the plastic plugger, different sizes, and you can use it to make the vertical condensation of MTA in the curved anatomies. Let's see another clinical case. This one with it's the young patient with 12 years old with a history of trauma in lateral incisor. They have pain, they have a huge apical lesion. It's possible to see in initial CBCT scan, I have a huge apical lesion without palatal bone. I decide to do the root canal treatment, cleaning, shaping, and obturation with biodentin. And there is the final X-ray. Biodentin is another bioceramic material. And I have here 3 months follow-up X-ray with amazing healing and 1 year follow-up with a great healing of all apical lesion without pain with the tooth in function. And I have here 6-month follow-up CBCT scan. It's possible to see the healing of palatal bone and healing of the bone in the apical area. To avoid the bacterial the leakage and to achieve a better sealing, we found in literature that we need to create an apical barrier around 3 to 4 millimeters length. Let's see about regenerative endodontics. In situations that we have dependent of the root development stage, as you see in this image, and in these initial stages of root development, in immature teeth with open and divergent apex that are not suitable to complete cleaning and obturation with traditional materials. In addition, because of their thin walls, these teeth are susceptible to fracture after treatment, and it's why we need to found a new technique, a different technique to try to allow the development of the root. And for endodontic regenerative, for endodontic regeneration, we need to have a trio of components. We need to control the inflammation. We need to have stem cells from dental pulp stem cells, apical papilla cells, and we need to have a biomaterial with some properties, excellent sealability, biocompatibility, and antimicrobial activity. And in this way, we can do regenerative endodontic. The clinical protocol I follow is protocol from American Association of Endodontics. I didn't go to explain the protocol, but I invite you to see the website of American Association of Endodontics to see the protocol, or this article from Dr. Diogenesis. You can follow the protocol in the same way. But these bioactive endodontic cements in revitalization provide a coronal seal. The main goal is to create a coronal seal over the scaffold and separate it from the coronal restoration. And in this way, using MTA, I can have a successfully coronal plug in endodontic revitalization procedures for teeth with necrotic pulps and open or closed apexes. Let's see this clinical case with 1 year and 10 months follow-up. I do the root canal treatment, I clean, I make a coronal barrier with MTA and do the final restoration. And after 1 year and 10 months, I can achieve two main goals. I can achieve the primary goal of this kind of procedure from regenerative endodontics. I can eliminate the symptoms and it's possible to see the healing, the bone healing. And I can achieve a secondary goal. I can increase the root wall thickness and increase the root length. Let's see another clinical case with 3 years follow-up. Same situation, same follow-up, same result in follow-up. I can improve the length and thickness of my root, and the patient can have healing of the apical lesion, and the tooth is in function without pain. And this last one, with 4.5 years follow-up situation, with root development, the healing of the apical tissue, it's possible to see in the last X-ray, these 4 years and a half follow-up, the parental ligament around the root without pathology. We didn't know what kind of tissue going to be here. Can be pulp-like tissue, bone-like tissue, cement-like tissue, it's not matter. The most important thing is I can give the opportunity to increase the length of the root, to increase the thickness of the root, and I can create conditions for healing. but sometimes the result is not the same. And we found in the literature and we found in our clinical practice that the results for apical closure and continued root development were inconsistent. And current evidence is unable to provide definitive conclusions on the predictability of regenerative endodontic therapy outcome. We are introducing new materials and new techniques in our practice. Probably the results in the future are going to be more predictable. And another huge problem that can appear in our clinics, the perforations. The old materials do not possess osteogenic, cementogenic, or antibacterial properties and are unable to ensure sealing of these perforations. And recent biologically active materials such as MTA give a great improvement in repair prognosis in these kind of clinical situations. MTA is the material of choice for sealing the pathways of communications between the root canal system and its external surface. Since the introduction of MTA and other bioceramic cements, the expectations on the long-term success of perforations repair are more optimistic than before the bioceramic era. But it's important for the clinician to understand that we have variables that can affect the prognosis of perforation repair, the time of perforation, location of perforation, and the size of the defect. The main step related to this kind of perforation is the access cavity perforation. And in this access cavity preparation, mainly in situations like this one with calcifications inside pulp chamber, with calcific metamorphosis, the risk of perforation is very high. As you see in this clinical case, we have a calcification in coronal part of my root canal, and the colleague sent to me these two X-ray from his wife. He tried to do the root canal treatment without rubber dam, first mistake, and second mistake, they didn't follow the long path of the root and they do a perforation in the lateral area. I found the root canal, I do the root canal treatment, and I seal the perforation with MTA. And I have here 1 year follow-up. Another clinical situation with a calcific metamorphosis, it's important to know about anatomy, is why in the beginning I explained the knowledge of anatomy is very important. It's important to understand that the root canal is always in the center of the root. I need to follow the long path of the root to avoid these kind of situations. The same situation, I try to have sensation, to find the sensation of dropping down inside pulp chamber. It's not happening in this situation because it's calcified. And the treatment produce a MISHEP iatrogenic event, like a perforation like this one, and they're going to decrease the outcome rate in these situations. The exploration for calcific can result in perforation. Perforation coronal and the choice of material I'm going to use is dependent of the area of my perforation. If the perforation is coronal to the crestal bone, I need to repair with restorative materials, such amalgam, composite, glass ionomer, cement. If the perforation is below to the crestal bone, I'm going to use MTA or other bioceramic material. Another clinical case, this perforation in the furcal area. I received the patient in this way with a Teflon tape and ERM. I remove the ERM. I need to clean all caries tissue. I need to reorient my access. I found 3 root canals. I provisionally seal the perforation with Teflon tape. I do the root canal treatment, the obturation. I seal my obturation material with glass ionomer cements. And after that, I'm going to clean my perforation site with ultrasonic tip to clean all tissue over there, to put a collagen matrix inside and deliver with my MAP1 device my MTA to the perforation area. And I have here, after the sealing of perforation, it's possible to see here, it's old perforation, it's possible to see here the bone was loose in the furcal area, and 3.5 years follow-up with completely healing bone in the furcal area and the tooth in function with onlay. Another clinical case, this one with a huge perforation in the furcal area. I received this patient with pain, They have a history of root canal treatment, not around 4 or 5 months earlier. They still have pain. They come to my office. I remove the restoration material. And when I reach the pulp chamber, it's possible to see here some composite in the floor of the pulp chamber. With a probe, I remove this composite, and in previous treatment was used composite to seal this perforation during search for palatal root canal. The palatal root canal is not shaped, it's not obturated. I only have the mesial buccal and distal buccal root canal. I clean everything. I remove all composite from the perforation. And in the same way, I'm going to use my ultrasonic tip to remove all this tissue from the perforation to clean the perforation site. After that, after cleaning, I'm going to use Teflon tape, and I put inside the perforation site the Teflon tape, sterilize the Teflon tape to stop bleeding, because they are bleeding a lot. And now I'm doing the retreatment. I'm removing gutta from distal buccal root canal and the mesial buccal canal. I found the palatal root canal in a different position, very near from the perforation. I do the root canal treatment, palatal root canal, all shaping procedure. Irrigation. And I still keep here my Teflon tape sealing my perforation site. And obturation. For obturation, I use a bioceramic material. After obturation, I seal my root canals with glass and enormous cement, and I remove now the Teflon tape from the perforation site. And it's not bleeding anymore. And for sealing this huge perforation, I decide to use biodentin, and I do a core with biodentin. I seal the perforation and I do a core with biodentin. I use my microbrush to make the vertical condensation of biodentin. And I finish the core with relics from 3M to make the core of the tooth and preparation for a provisional crown. There is the final X-ray and 6 months follow-up with a provisional crown without symptoms, without pain, with the tooth in function. The bioactive material Mta has significantly improved the prognosis for repair of perforation defects. Successful repair of perforations that were once considered hopeless will become possible using these kind of materials in our daily practice. In resorption situations, we have several case reports and case series illustrated the use of bioceramic materials to management of both internal and external root resorptions, either through surgical or non-surgical approaches, and various types of bioceramic materials were used for managing root resorption, including the Mta. We need to accomplish three main factors. We need to remove the resorptive tissue, prevent return of resorption, and maintain or regain the strength of tooth structure. We have some advantage using bioceramic materials like I show you in the beginning. They tolerate moisture, they tolerate small amounts of blood, they provide an excellent seal to dentin, they have antimicrobial activity, and they have mechanical characteristics close to dentin. Let's see this clinical case, cervical inflammatory resorption. There is a CBCT scan from this resorption. I do a surgical exposure from the resorption, put the rubber dam, and the resorption is in this buccal area and lateral area. I do the access, I do the root canal treatment, and I finish my obturation with, I use for obturation a bioceramic material, and I finish in the limit of my perforation, and I seal this obturation with the glass ionomer cement. You can see here the video. I open the access. When I reach the pulp chamber and perforation area, it's possible to see here the gutta perca. I do the root canal retreatment, remove gutta perca, shaping procedure, irrigations infection protocol. And now I'm going to do the obturation. I'm using a master cone with bioceramic sealer. I'm going to cut the master cone in the level of the perforation, vertical condensation, and sealing with bioceramic material. After that, I'm going to remove the obturation material is sealed with glass ionomer cements. I'm going to clean all tissue I have here, and I'm going to seal my perforation and make a core with biodentin. And I do the final restoration in the occlusal part, but this part, the buccal part, lateral part, I left the biodentin exposed to dental environment, to extraorally. In this situation, I have the mobility of the tooth grade 2, and here, 6 months follow-up, mobility grade 0, physiologic mobility, and final restoration. And I can keep the tooth in the mouth of the patient without problems in this way. And using of MTA in obturation, the cytotoxicity of many conventional and resin-based endodontic sealers has been well documented in the literature. The traditional obturation methods do not provide an effective seal. They shrink on setting, they have little or no adhesion to dentin, and are not dimensional stable when they come in contact with moisture. The weakest point is the sealer. And when you see the literature, we have some studies, in vitro studies, using different techniques of obturation. Imagine thermofill wave condensation technique, thermocompactation, single contacts, and they can still have voids inside space without any kind of obturation material. And our goal is to promote a completely seal of root canal environment to avoid the growth of bacteria inside the root canal system. And MTA canal obturation offers an innovative method to approach challenging endodontically involved teeth that may not respond using traditional filling materials and sealers when extensive patosis is present. And MTA and other obturation materials may not be the ideal in this regard. MTA can provide important advantage, as I showed in the beginning, due to its bioactive and bioinductive properties, as you show in this table. I have here this clinical example, an obturation with MTA in distal and mesial root canal with a huge apical lesion and 1 year follow-up with a very, very nice recovery. And another case from my friend Dr. Yoshi Terauchi, and in the web, the page of Dr. Itoshi in Facebook, you can find a lot of clinical cases, very, very challenging cases with a huge apical lesion, with cracking like this situation, and they obturate all root canals with MTA, with an amazing and fast recovery of the apical lesions. The application of bioceramic technology has changed both surgical and non-surgical endodontic treatment, providing the promising direction for the preservation of patient teeth. And I am going to finish my lecture with this clinical case. It's a upper central incisor with a huge resorption, inflammatory resorption of the root. The patient have pain. They have a trauma with a fracture, and they feel pain. I decide to do the root canal treatment, to do all obturation with a small root canal. Of course, it's not a completely root canal because the perforation make communication between the inside root canal system and bone. And I have here one here follow-up X-ray without pain, with tooth in function. The CBCT scan after this period of time, it's possible to see that in the first CBCT scan, I have a lesion in the bone. In this one, I have growth of bone in this part of tooth. And now 2 years of follow-up. It's a very, very good outcome. A hopeless situation can become hope in this kind of situations using the adequate material and the adequate armamentarium. I would like to thank you your presence here. I hope you enjoy my lecture. I left here my email and my website, and I invite you next May 2020 to come to Prague to see Root Summit. And we didn't have about the hypersensitivity report to MTA. I know I didn't know any case, any reported case related to this hypersensitivity related to MTA. Yes, about the overextension of MTA. If you have any kind of problem having the MTA, this overextension of MTA, we found in the literature is not. It's an article in publication. It's not yet public available, but they showing us with histological studies that in situations that we have an over obturation with MTA, we can achieve a better healing, a better bone healing in these kind of patients, better and a fast healing. I think we didn't have a problem when we have an overextension of MTA, but the main problem is in some anatomical areas. Imagine if you are working in the sinus area, or if you are working near from a nerve, the risk of compression is high, and this way it's why it's important to avoid this overextension. Alex, I think when the term bioactive is related to the ability to allow the healing, the cicatrization, they allow adequate environment to the cells growing, and the products they going to produce, the calcium hydroxide, they going to create like a chemical signs to call to the cells to come and attach to the MTA. It's why they are called bioactive. It's not. It's an inorganic material. It's of course it's an organic material, but their action and their byproducts can help help the body, allow the body to recover, and allow to the cells to growth in their structure. I have some cases from when I used the previous version of MTA with some color changes. With the new bioceramic materials, I didn't have any kind of some color change. Probably yes, I did, but it's not the gray color. It's not the same gray color that the patient realize and the patient complain. But even imagine if you didn't have nowadays the same materials, if you didn't have these new materials that reduce the risk of discoloration. With MTA, we need to make the evaluation between benefit and the bad side, the color change, because they can give the opportunity to keep in the mouth of patient situations that prior to the introduction of MTA in the market, it's not possible. And I think it's important to explain to the patient the advantage to use these kind of materials, the risk that they can have it using it, and solutions to solve these problems. Normally, for the application of the MTA as a Piccolo plug, I imagine if my working length is around 20 millimeters, I keep around 1 millimeter shorter. I try, if I have an apical lesion, try to do my apical stop with collagen matrix, and after that, I'm going to put my MTA 1 millimeter short from my working length, and I'm going to do my vertical condensation, and I always do X-ray control after each application. To solve color change, you can imagine if the patient is a young patient, you can use the new ceramic rounds in these patients to try to change the color, the gray color that can appear in this tooth. The only way is to make the restoration or even a crown in this kind of teeth. The best technique to obturate with the MTA you can use for obturation. You didn't need to create a huge preparations like Yoshi show with their clinical cases. They do the obturation with MTA even with small preparation size. They keep the consistency of the MTA not so hard, and they use and you can use for condensation the thermophil pluggers, the plastic pluggers, to help you to deliver the MTA to the apical part, to the working length. Yes, I have the obturation cases like I show you in the past lecture to do the obturation with bioceramic. Um, I only do the obturation in challenging cases with MTA. You can use putty type if you want, or even MTA, normal MTA. You can use for obturation. The cases I show, I use a normal MTA. The technique for obturation with bioceramic, you need to choose what kind of material you are going to use. Imagine the putty type, you need to do your instrumentation, your working length determination, and after that you need to put small amounts of putty type. I didn't like to use putty for root obturation in normal situations. I only use putty type to make an apical barrier or do obturation in a large root canal because it's quite difficult to deliver the material to the apical part in with the small preparations. And in these kind of situations, you can use the new bioceramic sealers, or you can use MTA and deliver small amounts of MTA and use your thermophil plastic plugger to help you to deliver the MTA to the apical part and fill all root canal with MTA. If there are no more questions, I would like to thank your presence in my webinar. Thank you so much. Hope you enjoy it. If you have any question, please contact me. Thank you.